You would think that this would be one for the boys. But men's sexual vitality is not just a he issue. It's both a physical and relational matter, which makes it a we thing.
Women have been conditioned that men are supposed to want sex all the time, and if they're not having sex all the time, that there's something wrong with our relationship. That must be something I'm doing.
Cuts two ways. Men have been conditioned that men want sex all the time, which means they're not allowed to say that they don't want to have sex.
So well said.
Seldom do we look at struggles in the bedroom from a man's perspective, because men just don't talk about it enough. But in my business, the most difficult conversations are the ones worth having.
If they're not having sex and fulfilling sex, it's going to play out at work.
Work is stressing them out. They are tired, they are frustrated, they're exhausted. I'm not doing great at work. I don't really feel like getting laid. I don't feel like I'm doing that great right now. Often women are quick to internalize a man's lack of sex drive. And all of a sudden the man's got no safe zone at all.
We're here to start this conversation and to introduce regenerative medicine to the forum.
From your perspective, has Western medicine failed the people?
Yes and no. I've seen a bunch of TikToks, oh, the doctor of the future is gonna prescribe weightlifting as medicine. Like, no, we did that for about 60 years and nobody listened. And this is where we are now. When doctors used to say, you're overweight and need to exercise more, and people weren't doing it. You know, early 2000s, you started to see, you know what? We're just going to give them the pills that they want because they're not dieting, they're not exercising, and they want solutions. Now we're seeing a shift again. People are framing it, oh, you exercise to live a quality life, not to lose weight. And all of a sudden, everybody's listening now. Regenerative medicine is to optimize and unlock the full potential of your biology where it is right now. There's a lot of tools that can backfire. There's a lot of other tools out there that you probably aren't aware of that can help you achieve those goals.
Medical doctors like Orel Swenson are singing the praises of regenerative medicine to optimize systemic health, and as a welcome outcome, to optimize your... Because what happens in the bedroom often plays out in the boardroom. This is the Meaning We Make podcast.
I am super excited to have my friend and colleague, Orel Swenson, here. He is an ex-Johns Hopkins ER doctor turned regenerative medicine physician in Montecito. Welcome. Thank you for coming to my podcast.
Appreciate that. Glad to be here, obviously.
I am excited about this conversation because of what I do for a living as a therapist and executive coach. Obviously, I'm not talking about men's sexual health as much as an executive coach, but I certainly am in therapy. And it's not talked about enough, in particular, so women can understand it too. Because a lot of times the way men end up in my office is because their wives are dragging them there. As a therapist, as an executive coach, they're coming to me more for sort of like light therapy, if that makes sense.
Yes, it does.
Right?
Absolutely.
And so your world and regenerative health, they're coming to you from a optimization standpoint, from a physical health well-being.
Yeah, they're coming in really with complaints of whether it's cognitive and performance issues, stress management issues, but by and large just trying to stay at the top of their game, male and female. Largely, again, they're already high-performing individuals trying to stay there as long as they possibly can, or age more gracefully, so to speak. They're already doing what they can from a lifestyle perspective.
Yeah.
They're already doing what traditional medicine and Western medicine says, okay, you know, to do for your blood pressure, for this or that, and that's fine. But it's, you know, I'm slacking at work a little bit compared to where I was 3 or 4 years ago, and what can I do differently? Or it's a slow recovery from yesterday's exercise, and man, just 5 years ago, I could bench press XYZ sets, or I could go for this run or that run.
So they're coming to me for relational issues. And it's ironic how sometimes they come as couples, and sometimes just the men will come on their own. But a lot of the time when it comes to therapy, they're coming to me because they're having relational issues. And so they're not as poignant about their sex lives. And it's ironic that a lot of times couples will come to me and they'll start talking about their communication issues, and then they stay away from sex. And I have to be the one to go in and be like, what's going on with our sex life, right? And I have to bring them into that conversation. So I wanted to just really bring that up at the outside of the conversation tonight. But before we dive in, let's talk about you. where you came from. You know, you started at an ER at Johns Hopkins.
Yeah.
So what the hell is that like?
Yeah, so I started the medical career as an emergency medicine doctor, largely in level 1 trauma centers, eventually getting to Johns Hopkins towards the tail end of my career. Very different from where I am right now, obviously. You know, the calling for emergency medicine was certainly around a high-paced adrenaline type work. And ironically, that's not the reason for leaving. You don't leave from adrenaline burnout. You actually end up leaving from the minutia that's not emergency medicine, because the ER plays such a safety net role. If you don't have insurance, if you don't have this, if you go to the ER and you can get care.
Wow.
So you end up becoming a primary care doctor as well, which you're not really fully trained to do. It's not the mainstay of the work, and that ends up becoming much more of your job than you planned on.
Wow.
So that, coupled with, of course, the shift work and the late nights and everything else, can take its toll on you. And you don't really feel like you're accomplishing that much when you are an intermittent primary care doctor. So I see you once, I certainly can't fix you long term. So all that, you know, led me away from emergency medicine to eventually where I am right now.
From the seat I sit in, you know, what a previous episode we had a firefighter, a Montecito firefighter, come and talk about the mudslide that happened here, the debris flow rather, and some of what it's like to be a firefighter. And, you know, there's vicarious trauma involved,
Sure.
and including for me as a therapist.
Those I see even worse than what we do, because I see it in the field.
Yeah.
At least I get a semi-cleaned up version of whatever happened. I'm not actually on the road.
Yeah.
So they have it even worse, for sure.
Yeah. But how does that impact you when you see it in the ER?
It never really hit me that hard from the trauma side. The ones that always bothered me, and the ones that I would say kind of stick with you over time, at least again in my case, were the terminal cancer diagnoses, because you just couldn't do a whole heck of a lot about it. I mean, you gave a diagnosis, you didn't really have a lot of opportunity for follow-up. You just kind of, all right, here's, you know, me ruining, well, more than your day, we'll say that. So those have always stuck with me.
You know what, that just gave me chills, because I don't think people ever think about what it's like to be you in those moments.
Again, it's a job.
Yeah, I get that. And then you did a pivot to venture capital.
Yeah, so I really thought I was going to be done with medicine completely. I went back to Duke, I got a business degree, and got into VC. And after about a year and a half of that, joined what might be called biotech, working on things, think about like your Apple Watch, but medical grade for doing clinical research trials. But perhaps more relevant to where I am now is, in tandem to leaving emergency medicine, kind of began my own, we'll call it health and recovery journey, in so much as, you know, no more overnights, sleep starts to improve, weight starts to come down. Now I'm exercising regularly. Now I'm feeling better about myself and you know, what the future might hold. And then I got into, and probably a good number of your own listeners may have heard of Peter Attia, the Mark Hyman, David Sinclair, all, you know, the Huberman, all the big names out there. Well, I got into that just for myself. I'm like, all right, I'm just going to get healthy, and leaned into the blanket longevity space. And ironically, you know, colleagues, friends, what have you been doing? You look so much better. You look so much different. So I started to do consulting in that. That became a bigger side business. And I left my last role to launch effectively a full-time clinic. At the time I was in Boston. Pretty much knew I wasn't going to stay in Boston. The East Coast in general, unfortunately, is very slow to adopt newer technologies.
Sure.
So I began eyeing a few different areas that I knew this was more openly accepted, not just by the potential patients, but also by the medical community as a whole.
Wow.
Ended up in Santa Barbara primarily because I had a bit of a network here already. So it kind of prompted me to come here. I mountain bike, I road bike, I like to sail, I like to trail run now. So leaving a January winter in Boston was not a hard decision.
Coming from the Midwest, I feel you. I feel you. I get that. So you mentioned a couple of things, which I think is really important for us to touch on, which is the adoption of new technologies. And now that you've moved into the regenerative medicine field, talk to me a little bit about how Western medicine may have failed us in not approaching things more from a regenerative medicine approach.
The term longevity medicine gets used a lot.
For sure.
But it does have meaning, right? Longevity medicine, at least as I would say, for those who read Peter T, have heard of like medicine 3.0, right? The idea of advanced primary care, and that's not a dig, it's more of, the goal was better labs, more insights, more biomarkers, get on top of things earlier on, whether through lifestyle interventions or earlier use of medications, as a strong foundation for, I think, where we need to be in terms of moving the needle into more preventative type primary care work. Regenerative medicine, I would say, is really a subcategory of the longevity medicine space, where if we say longevity medicine ends at advanced lab work and advanced or proactive lifestyle interventions, then we say regenerative medicine takes over by saying, okay, you've done all the lifestyle things that you can do. Sleep optimization and your blue light glasses, whether it's lifting weights 3 times a week and going for your, once a week interval training exercise. You've cut alcohol, you've done all the right approaches. You've eaten minimal processed foods. You've done what you can.
Yep.
Say what you can on purpose, because it doesn't mean you've done everything, right? A lot of the clients that I'm seeing in the regenerative space, I have a gentleman who's high-level sales role, and he goes out with clients 3 times a week, has a martini every single time. That's not going to stop.
No.
That means dinner out 3 times a week. That's not healthy.
Yeah.
That means a drink 3 times a week or more. That's not really healthy. Does that mean we're going to change that? No, his lifestyle doesn't allow for that. He lifts and he runs and he does what he's able to do. But he goes to bed at 11, 12 o'clock more often than not, even though he's getting up at 5 or 6. So regenerative medicine has really 2 approaches here, but with one main outcome, which is to say, okay, given what you're doing with your lifestyle, whether it's as much as you can or as much as possible, as much as you can, what other tools are there to optimize and unlock the full potential of your biology where it is right now? If you're slightly overweight and chronically sleep deprived and this and that, your full biological potential is less than somebody who's semi-retired at 45 because they're a tech millionaire and able to work out 5 days a week, and that's fine. But we can still unlock in both of those something more than just giving them some pills and just saying sleep some more. And that unlock comes in the form of everything from hormone replacement therapy, known as HRT, which for men is often qualified as TRT, testosterone replacement therapy.
Yeah.
So comes in HRT, comes in potentially peptides, stem cell exosomes, again, all of which we can unpack, and other tools we can bring to the table to say, okay, how do we bring out the best of your biology for where you are in your life right now?
Right.
And that's, I think, where longevity medicine ends, essentially, and regenerative starts to begin.
From your perspective, has Western medicine failed the people for a long time until this really has emerged?
I'm going to answer this in a way that may not make me a lot of friends. Yes and no. I've seen a bunch of TikToks and Instagram and TikTok videos. Oh, the doctor of the future is going to prescribe weightlifting as medicine. I'm like, no, we did that for about 60 years and nobody listened. And this is where we are now, right? When doctors used to say, you're overweight and need to exercise more, and people weren't doing it, or need to go on your diet. And this ended around the time that I started med school, which was, early 2000s. You started to see, you know what? We're just going to give them the pills that they want because they're not dieting, they're not exercising, that is the average patient, and they want solutions. Now that then led into a very vicious cycle of, well, the expectations are there's a pill for this. I don't have to do the exercise.
It's true.
And of course the Western, okay, well, I guess we'll give them the pill. The pill makes people happy. The people are happy. They come back. They take more of the pills. To say nothing of the, the pharma complex overlying all of that, there was part of it in American culture of like, I don't want to do the really, really hard work.
Couldn't agree more,
to get there.
Doc. Couldn't agree more.
And now we're seeing, I like to think, a shift again. It's funny, our kind of pre-podcast conversation was around how you frame things. People are framing it, oh, you exercise to live a quality life, not to lose weight. You do your interval training because you want to be able to travel when you're in your 80s, not because you're worried about how you look. And all of a sudden, everybody's listening now. So it's very funny. I think it's
the framing matters. I mean, how we serve things up in what I do, what you do, really matters. But a lot of times, it's also what's being presented. But what I think I heard in what you said, yes, the Western medicine was right back in the day when they said you should weight lift more. But people weren't adopting that, and so Western medicine needed to adapt to fit what people did or didn't do.
As a doctor, right, here's the counterpoint, right? So you have a patient who's got high blood pressure, who's overweight, and does not want to exercise. So you can tell that patient to take a hike. Well, that's not morally acceptable. Or you can give them pills for their blood pressure and their cholesterol problems.
I hear you. And let me just throw something in from behavioral science. What I've learned and what I do, a lot of times people just need a fucking win. They need even a minor win which might be to lose 5 pounds
Yep.
before they're willing or capable of seeing what's the potential.
Yep.
That's what I see frequently, which is sometimes people need to go through the simple way first to get that win, to then say, now we'll invest the hard work.
That's fairly accurate. Again, I don't think it played out too much in the past several decades of Western medicine as it pertains to America's primary lifestyle issues, which are obesity
Sure.
and subsequently metabolic issues, including diabetes, that then drive, even to this topic, sexual health concerns
Yep.
and everything else downstream. Blood pressure's down, but that didn't do anything for motivation. So I think Western medicine started to do what people needed, and then kind of like any almost codependent relationship where both were doing what they shouldn't be doing. The patient said, I'm not going to exercise. The doctor said, I know that you could do better with exercise, but here's the pills anyways. And you got in this vicious loop of, well, I guess I don't really need to exercise. My numbers look better with my pills.
Yeah.
All of a sudden, being over like 20, 30 years, we created an industry that said, okay, well, we both know what the expectations are. We both know we could do better, but we're happy with this kind of misaligned, semi-okay
That sounds like
relationship
a
here.
relationship managing for decline in marriage. I mean, it's a very similar dynamic.
And here we are.
Wow. Can I take us back to
Sure, of course.
NAD, exosomes, stem cell therapy? What the hell? I don't even know what to do with half of this.
Yep.
And quite frankly, as a clinician, I like when someone presents to me in my office, you know, whether it's a woman with brain fog or a man talking about his stress, I have to sort of take a broad stroke. I'd be working out of scope if I was like, oh, we got to test your testosterone. But I say, have you seen a doctor lately?
Sure.
So I welcome you to both educate me and other clinicians, because we need to know this shit, but also obviously the general public. What are some of the other things that could be at play that you get to work with as a regenerative medical doctor?
When you think about regenerative medicine tools, whether it's NAD, whether it's stem cells and exosomes, whether it's peptides, whether it's hormone replacement therapy, etc., what we're really talking about is how can we address things at a cellular or even mitochondrial level to move the needle, as opposed to just addressing it from a systems perspective. So this, we can use as a segue momentarily, but erectile dysfunction.
Yeah.
All right, so traditional medicine says, here are pills to help with vasodilation, so Viagra, Cialis, etc.
Yeah.
And hopefully the mechanics of that will be enough. That's not necessarily the underlying cause, right? What about blood vessel health? Okay, well, how did we control blood pressure? Underlying inflammatory changes. Did we address, you know, any gut health inflammation and issues? Did we address your insulin sensitivity concerns that are driving the picture in front of you right now? And all this is, again, where kind of regenerative medicine comes in is, so something like NAD, at least in theory, can help with what they call ATP. ATP is the end fuel source of anything you eat that your cells use. So I don't care what you eat, eventually it becomes ATP. That's, you know, it goes to your mitochondria, which is your oil refinery. Mitochondria spit out ATP, and that's what your car, your cell, burns.
And ATP stands for?
Adenosine triphosphate.
I will not be repeating that.
Excellent.
Okay.
But so you can think of the mitochondria, which live in the cell, as the oil refinery for making ATP. One of the fuel additives for making ATP is NAD. It decreases with age. It decreases as it gets used for NAD for DNA repair as well. There's oral supplements that have been shown to improve NAD level. There's ways to get it by IV and by shots as well. Well, NAD, that improves the mitochondrial's ability to put out ATP, your ability to, you know, make fuel. What downstream effect might that have if your cell is healthier? If we start talking about using those levers, in addition to the rest of them, not just in place of, but in addition to the rest of them, we really move the conversation of how deep we can get for fixing the core problem. ED is a label, no different than depression. It doesn't actually say anything about what's going on inside that person biologically. We often treat depression as depression and not necessarily as a complex set of issues. How is your estrogen, your testosterone? How is your inflammatory load? Are you chronically sick? Are your cortisol levels fluctuating normally? And is that being checked? And even if we check it, who do you turn to fix it?
Well, this is interesting to me because a lot of people don't know that, like, when you go to your primary care physician, they're also not checking it.
Right.
That is why going to someone like yourself as
Yep.
a regenerative medicine doctor is so important if you can access that.
The big limitation for any primary care provider inside the system of insurance-based care is how they have to work. And it's crass now, but it's true. They are very much so factory workers. They have production quotas to meet almost
Wow.
literally. They have a number of patients to be seen every day, period, in a very small window. 5 minutes, 15 minutes per patient, often double booked. And they don't have the time to discuss those tests. So no matter how much they care, they can't perform outside that box. And to do it right, it becomes a much more individualized conversation. You know, how experimental do you want to be? What risk-benefit ratio do you want to discuss here? Here's what I know and don't know about peptides. Here's the risk as it pertains to you. So too for stem cells or anything else we're dealing with. Now enjoy having those conversations. That conversation takes an hour before we even begin making decisions. That's like just bringing you up to speed on all the tools available to you.
And you're saying, like, hey, I'm going to actually sit down and prescribe what makes sense for that person and customize it more for the lifestyle that they're at that phase of life.
Yep.
In my world, that's called meet the client where the client is,
Yes,
right?
same concept, exactly
Yeah,
right.
makes
Yep.
sense.
The goal is not to tell them to change everything in their life. They already know that. By and large, people seeing me
Yeah.
are doing everything that they can do already from a lifestyle perspective.
Yeah.
Not necessarily everything there is to do,
Right.
but everything that they can do.
Sleep, more
Yep.
sleep, you know, all
That's what
the
they're-
exercise,
so
blah, blah,
they're,
blah.
They're coming to me saying, okay, what else?
Yeah.
Because I know I'm not where I can be or where I want to be.
Yeah.
What else can I do?
Which is so super exciting to me because my experience with most people, and I've even done this myself sometimes, is they have to wait for a higher level of impairment before they're willing to make change. And
Yes.
so I'm
Yep.
always like, what would happen if people would actually come for optimization as opposed to, I just can't suffer anymore?
Yep.
Okay, so you brought up ED, so let's get down to sort of like, I have long said what happens in the bedroom plays out in the boardroom. And I predominantly mean that we can't bifurcate our lives, no matter what anyone says. We can compartmentalize as a strategy, but the dam breaks and you can't compartmentalize anymore. And what I know for sure is that particularly things like depression, it plays out if they're not having sex and fulfilling sex as one measure of sort of joy in life, coupled with other stressors and relational challenges, it's going to play out at work. And they are, you know, cranky, indecisive, irritable, and that then has a ripple effect to stopgaps in hiring, in poor decision making, and et cetera, et cetera. So I'm curious
Yeah.
about, from your perspective, what do you see around that?
I'm going to call you out a little bit, even the
Go for
way
it.
you phrase it now, which is, I would say, a common issue that men have, which is you said, well, they don't have sex, therefore work suffers. Women sometimes get this backwards. Work is stressing them out. They are tired, they are frustrated, they're
Yeah.
exhausted, they're doing the best that they can at work. And they come home having no sex drive. And, you know, I would say that very often it plays out that women are quick to internalize a
For
man's
sure.
lack of sex drive.
Yeah, for sure.
And all of a sudden the man's got no safe zone at all.
Yeah.
I sure as hell can't talk about it at work. These are people I'm working
No,
with,
no,
so
you
that's
can't.
not gonna happen.
That's not a good place
Men
to do
don't
that.
talk about with their buddies. That's
yeah.
not a thing.
Yeah.
And now I can't talk about my wife anyways.
Yeah.
And now I'm worried that I'm not gonna do a job at work
Yeah.
and I'm not performing sexually.
Yeah.
So now she hates me for two reasons.
Yeah.
Great.
Yeah. By all means, always call me out because I'm always here to learn. I was coming from the bedroom to the boardroom, but certainly the boardroom can make the bedroom less appealing.
Yep.
Right? For sure. It's a bi-directional impact, an emotional spillover.
Yeah, I would say a lot of high-performing men and women, right, that career is very much so a sense of identity, unsurprisingly.
Yeah.
And the second that the career is going a little bit off the rails or just unbelievably busy and stressful, that reflects on self-image. And that self-image goes down. Men have self-image just like women do in terms of, well, if I'm not doing great at work,
Yeah.
I don't really feel like getting laid. I don't feel like I'm doing that great right now.
Sure.
Now, not all men are like that, obviously.
Sure.
We're talking with excessively broad strokes.
So how do they present to you? Because I know how they are presenting to me, and I'll just quickly summarize that as sometimes when it's therapy, it will be brought to me as a couple. Oftentimes, if it's a heterosexual couple, the wife is bringing maybe dragging their husband to therapy to fix the relationship. And for her, often, it is after she's nagged, we'll say, about that I'm not happy. So they come, and again, it's not always that way. Sometimes it's the man. I'm making a sweeping generalization. And she'll say, I'm not happy, we're not doing well, we need to work on our communication issues. And then, as I said earlier, like, bring up sex. And that's where I discovered they aren't having sex for 5, 7, 10 years. And I'll be honest, I'm astounded by that, because I know that sex is a huge part of play and bonding, right? And obviously intimacy. And it breaks my heart when people tell me that they are 90 and not having sex on a relatively regular basis, whatever that is for that couple. But there are so many clients that do not, and they just sort of like start drifting apart. And to your point earlier about sort of like women and making it about themselves, like, I think women have been conditioned, I'm a woman, women have been conditioned that men are supposed to want sex all the time. And if they're not having sex all the time, that there's something wrong with like our relationship, that must be something I'm doing, that they don't desire me. It's both, right? Like, obviously I work with a lot of men, so I see it so much from their perspective, and my heart breaks for them. And I'm a woman. I want to know if there's something I'm doing that's causing it. Not that I need to make it about me, but I need to know if there's something that I can do to inspire that. I want to be able to hold myself accountable. And so I think it's interesting to just have this conversation, because most people don't hear this kind of conversation. So in part just in being humans and being different genders, but in part from how do you see it show up in your office? We're saying erectile dysfunction, but do the men come in and say, I have erectile dysfunction?
No, not per se. I mean, some do for sure, or they've already been diagnosed with it previously by their primary care doctor. But you said it, and I think it cuts two ways. Women have been conditioned that men want sex all the time.
Yeah.
Men have been conditioned that men want sex all the time. Which means they're not allowed to say that they don't want to have sex.
So well said, yeah.
So
I think that's right.
Again, if they lose sex drive because of work or not, they're like, oh, that's something wrong with me.
Yeah.
Again, they assume that there's something wrong with them as well. They go, I'm supposed to have sex all the time, right?
Yeah.
I should be 90 and still wanting to have sex.
Yeah.
So they have the exact same mindset the women do.
Yeah.
And so for that reason, often when I'm talking to men, the words are never, not having enough sex or this or that. And again, admittedly, I'm not a therapist. They're seeing me under a very different presumption.
Yeah.
And how they approach me is going to be very different than how they approach you.
Yeah, yeah.
Nonetheless, well, stress is very high right now. I'm not sleeping a lot right now. Things could be better at home, etc. It's vague terms. I wonder if my testosterone's okay. We should check that. I want to put on more muscle mass. I want to look better. I mean, men have the same thought process of, well, so who's at fault for not wanting sex? Is it, am I putting on weight? Am I not looking as good as I used to type thing? In addition to the fact that I'm losing my drive, or it seems to be diminished. But the terms are different, right? It's, check this. I'm stressed. I'm tired. I'm not
type
sleeping
of stuff.
very well. For me, they're coming at it with different terminology that I have to tweet out a bit.
So what are some of the most common men's sexual health challenges that you're seeing in your practice?
Libido mismatch, I think, is up there more often than not. I mean, I've even seen, guys like that. I have low T, but my wife is perimenopausal and she doesn't want it anyways. So
and what do you do with that?
Let's not fix my testosterone right now.
So let's not fix it. Oh, fascinating.
They'll say, let's not address it. I've heard this on multiple occasions.
That's fascinating. So
because they're concerned that libido gets better and it'll make things even worse.
Yes. That's what I'm hearing when you say that. That's fascinating. Right. Okay, so mismatch and libido. Okay, keep going.
Again, you start to hear like, oh yeah, I want to make sure that I a little more drive or this or that. Is they certainly, men will certainly talk about wanting more drive, more interest a bit as they get to know me, a few sessions and whatnot.
Does that go back to your previous statement around men are also conditioned to want sex all the time?
Yeah, or to condition to think that they should.
Yeah, exactly. That's probably a better way of saying it. Thank you. And so they could be okay with having maybe a little bit lower sex drive as aging and all of that happens. But if their wife is,
Yep.
if we're talking heterosexual, or the partner, we'll just say,
Yep.
but because they also are driven by this societal ideology or pressure to want to be getting it on all the time, they themselves are saying, I might need to fix this.
Yep. And then, I mean, here we also have the fairly common large age discrepancies for men and
Okay.
women here. A guy 15, 20 years older, she's got a much higher drive, and he wants to match that
Yeah, yeah.
and wants to figure out how to do it again.
Uh-huh.
You know, as far as how to have that level of energy, drive, sexual interest again. But when you're talking that large an age drop, it's a challenge.
Talk to me a little bit about some, because I know that some of the women are coming to you, even though, you know, that we've been talking primarily about men's sexual health, but the flip
Oh, yeah,
side of that,
definitely.
what are some anecdotal sort of challenges you're seeing in part relationally as it pertains to women and their sexual health?
Well, it's interesting. It's kind of reflective of what we've discussed thus far, which is very often women are coming saying, I want to have a higher sex drive because I think he wants a higher sex drive.
Okay.
I'm being serious.
No, I believe you.
They're not asking like, does he? We're not having couples come in here having that conversation of like, well, did he voice that he's disinterested in
They
you?
probably were talking to their girlfriends, to be
Potentially.
honest with you.
Yeah.
Yeah.
So I get that, like, oh, well, I should have a higher sex drive because I'm sure he wants me to have a higher sex drive. I'm like, does he? Are you sure? Have you asked? Are you guys maybe just perfectly in tune? And of course, some of them are like, yeah, well, he's asking and I'm not interested, so we got to do that. Of course, that's a very obvious mismatch. Fine.
What do you do with that?
In terms of intervention based?
Yeah, yeah, exactly. From a physiological perspective, like how do you treat that?
So again, depends on the person, but obviously we start off with comprehensive lab panels. Again, HRT may enter the equation, may not. There's actually an FDA-approved medication known as bremelanotide, or PT141.
Okay.
That is a type of peptide that was actually approved for low sex drive, low libido in perimenopausal women.
Oh, whoa. This is
And it acts
fascinating.
centrally. Yeah, it never gained a lot of traction because primarily it was done as a sub-Q shot. It's also available through compounding pharmacies as a nasal spray. Doesn't work for everybody, like anything, and that's part of where I think it lost some of the marketing cred because expensive drugs that don't work for enough people, they just ditch them. But interestingly, they found that it also helps men. So there are multiple tools for women as well, and it gets back to the issue of why you're not having enough sex. Is it psychological? Okay, then you need to go see a therapist. Fine.
Right.
Is it hormonal? Is it all the perimenopausal, is it dryness issues and whatnot, which are eroding your confidence?
Right.
Are you feeling, well, I just feel bloated all the time and a little overweight? And again,
self-esteem.
quickly this becomes a mixed bag. And I try the best that I can to stay in my relative lane, obviously while recognizing how it all interplays. Hormone therapies and other interventions as they might pertain to improving muscle mass, improving mood and stability, decreasing hot flashes, etc. All that all goes back to, I've slept through the night, I feel better. Maybe I want to have sex now. No surprise, obviously, but again, it all plays together very quickly.
I think you've mentioned to me in the past about oxytocin. Have you?
Yep.
Tell me more about that and tell the audience a little bit about how that works.
Again, in conjunction with the PT141, often used for improving effectively central motivation and drive for sex, and just an interest in libido, connection, etc. for both men and women. I want to be clear that these are not like, oh, just go buy a bunch of oxytocin and take it. And yes, it works for some. Doesn't work for everybody. Data is mixed. Part of why this stuff hasn't gone quite as mainstream is because you don't have consistent data. Sometimes it's like, oh, it's just placebo-based. For the sake of a sidebar conversation, you remember for a little while there was the green M&Ms make you horny.
I don't remember that, but
So
let's
green
bring that
M&Ms
back.
Green M&Ms make you horny. They don't, of course, unless they do, in which case eat green M&Ms. Who cares?
Right,
So
right.
so too, this is like with the oxytocin PT140. And again, this is a little more than M&Ms, obviously. They actually have scientific mechanisms that actually do work, but nothing works for everybody.
Yeah, right.
But they can, again, in part address drive, and when paired that way, show evidence, do work in some. And it's part of just, again, a multiple angle approach is where the regenerative part comes in. Male or female, okay, can we get your stress under better control? Can we drive better deep sleep even if you only got a 5-hour window and therefore normalize your cortisol variations through the course of the day such that you are relaxed in the nighttime and your cortisol is not spiked all day long and your heart rate variability is improving, and so you feel better about this and that, and all of a sudden, oh look, I have a sex drive back. There's multiple levers.
So what I'm hearing is like it's part, because in some ways it's how I work. It's like obvious pattern recognition from like things that we've treated for decades and decades of like where we kind of know to go based on sort of what's being presented to us in symptoms.
Yep.
And part just, well, let's try this and tap, 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 and let's try this, tap, 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 and how did that work for you?
Yes.
Right? That's kind of how I'm hearing
There's
it.
definitely a part of that.
Yeah,
Yep.
for sure. So
Nothing works for everyone, which again, I think is a big differentiator when you get into regenerative medicine, but even, concierge medicine in general, there's time to talk to you about like, look, let's try this. It works for 65% of the population. That's not a slam dunk, but it's not terrible. You might be one of those 65. Let's try. Give it 2 weeks. In 2 weeks doesn't work, we're going to abandon this medication and change to another. We're not going to pile more stuff on you. We're going to say, okay, we did a trial window. It's not effective. 2 weeks, 2 months, whatever it might be, depending on the tool at play. But those conversations require you to be able to closely follow up with your patients, explain yourself well, explain your thinking well, set expectations fairly, so that people don't get frustrated. Hey, this didn't work for 2 weeks. Nothing works. No, we said it might not work. That's okay. If you've teed them up for that, and I think you probably are aware of this too. If it's expectation management of it didn't work for you, we have other tools.
100%.
People aren't mad when they think it's the only tool in the box because you ran to your PCP and they gave you your Viagra and you went home and that was the end of it. And
It's catastrophic.
like, yeah.
This is how I have to live life the rest of my life, if that's
Right.
what they
This
think.
is the best I got.
Right.
And it doesn't even work. The hell am I going to do now?
Yeah. Yeah. And then everything else is going to fall apart. If
And
my penis doesn't
you
work.
get no, of course. And now the spiral just worsens real quick,
Yeah,
right? And this is to
100%.
say nothing of the fact that, well, again, we're saying, well, why isn't your penis working?
Yeah.
Why are we just saying, oh, take some meds? Well, you sure that's the answer?
Right. Yeah. No.
What else is going on?
Yeah, exactly. Okay, so let's talk about sperm quality, because I
Sure.
knew that there's been some new data out that I think people need to know about. And I don't want to freak everybody else out there, but penis atrophy.
That one, thankfully, is less concerning. But yes.
Okay. So let's talk about those two things.
Yep. So sperm quality is not less concerning. It's actually a very, very big problem, particularly for couples trying to get pregnant. Data shows substantial reduction in both the amount of living sperm as well as their motility, the physical ability to move and swim, particularly starting in the early 2000s. It was a little bit declining from the 70s to the 2000s, and then it kind of rocket ship declined, such that we're at about half for the average man where they would have been in the 70s to 80s in terms of sperm quality.
Okay, well, okay.
Right. And how does that
Wow.
track to healthy babies and other things? And this is where I'm not going to touch this because no one knows yet in terms of, well, does this increase the risk of inherited genetic diseases, this and that? We know it's true for women and egg quality and advanced maternal age and all that stuff. We are starting to say, well, men might not have a full clock, so to speak, but there's degradation in sperm quality, and that can lead to increased risk in the fetus, et cetera. And again, I'm going to stop at that level because it's still pretty crass and rudimentary data, so to speak.
Yeah, I've read some things, and we've had this conversation, so I won't say it out loud. But I've read some, data around like men's sperm quality after 40 and what that might suggest and produce in terms of children. And I'm just going to throw this little thing in there because I'm a woman. And like, and why the hell weren't we discovering and
sure.
researching this 25 years ago?
Oh, absolutely.
Right.
If you wanted to go to med school and redefine yourself in the next booming industry, it's going to be men's sperm health.
Wow.
I guarantee it. As far
You heard
as
it here.
It is. I mean, like, it's going to be just as large an industry. I would place money on it as women and IVF and egg freezing.
Wow.
It's going to be this realization of like, well, why not freeze your 21-year-old sperm when you're peak everything?
Wow.
And you haven't been through 20 years of corporate hell and stress and this and that and cortisol levels and DNA damage. So
Do you
why not
think
just
men
bank
will?
that now?
Do you think men would do that?
I don't see why they wouldn't.
Yeah, interesting.
Cheap and
Framing.
easy compared to IVF as far as collecting and freezing. This
Yeah.
is pennies compared to tens of thousands of dollars
Wow.
for IVF.
Yeah.
I
Sorry,
think
carry on.
that's- Yeah, I think that's certainly coming pretty soon. The why of the low sperm quality seems to be the obvious next question, which is to say, almost certainly, multifactorial. What are those multifactorial aspects? Some mentions of, is carrying the cell phone in the front pocket a problem?
Wow.
Not really sure. There is clear evidence that heat and sperm quality go hand in hand, or lack of sperm quality go hand in hand. So heat from the phone versus, magnetic frequency radiation, etc. No one knows. Is it a slam dunk correlation? Not really. Some soft evidence there, but it's there. And
Keep
then
the
things
puns
in the
coming.
food.
Some soft evidence there. Sorry.
It's true, yeah. Plastics, BPA, etc., seem to affect sperm quality as well. So we're seeing, so this stuff builds up, causing DNA
the
damage.
plastics from like eating food out of a plastic container,
Right.
or plastics from okay.
Yes.
Okay.
So when you heat up your food in your plastic container and whatnot, and all
And
the,
that's affecting your
BPA
sperm
and
quality,
phthalates,
possibly.
seems to be.
Wow.
Yep. Again, multimodal as far as multifactorial, why it's been decreasing so much. But those seem to be the most obvious culprits in terms of what everyone's exposed to. To say nothing of the pesticides in our food and everything else that are very hard to unpack and really understand what it's doing to us long term.
We have briefly in our, walks on the beach or at coffee talked about penis atrophy, which was pretty interesting to hear because I've never heard of this before, and it certainly hasn't walked into my office. So Can you tell me a little bit about what I need to know about that, because it does come into my office?
Thankfully, not much. It is a real thing that can be a problem in a few medical settings where you have persistent low blood flow to the penis, usually from underlying issues, whether it's cardiovascular health that's persistently unaddressed. Prostate issues can also contribute to it. But the one that most men think about is, well, if I don't use it or lose it kind of thing, is that a real issue? And the answer is not really. There is actually small amounts of atrophy that can occur if you're absent for long periods of time, but it reverses more or less immediately. So it's not something for most people to worry about, thankfully.
So some man can say, hey, you have to have sex with me, my penis is going to atrophy.
I mean, it's a useful line. It's real. It's just not might be enough
but
to matter.
But then the woman could be like, it'll come back, don't worry about it.
Well, it'll come back if you do more.
There you go. There you go. All right. So we often see men that are like mid-30s to, I don't know, for me, like 60, 65, and vastly different challenges in life. And I'm curious from you, what is your experience of what's happening to a guy that's like, hitting his 30s to 40s to 50s? Like, what do you see from a lifespan perspective in sexual health?
Yeah, I think one of the things that's worth calling out, it's pretty well established, though the reasons behind it vary, that we don't age linearly. You don't just get a little older every year. When somebody says that 40 hit me like a train, so to speak, or 52 came on and all of a sudden, I went downhill fast and I really feel like I'm aging for the first time ever, that is not in their head. Aging does seem to hit. There are certain decades, and I want to say late 30s, early 40s, unsurprisingly 50s, late 60s and the 70s, where there's substantial step downs in your health and your sense of health quality. And that maps out in a number of ways, but as a rough timeline, right? A guy in his 30s, late 30s, hits the gym, lifting, is like, yeah, I can maintain, but I'm really not putting on much muscle mass. A guy in his late 40s, early 50s is like, well, I gotta work really hard just to keep things going as far as muscle goes and health. I'm just, to say nothing of libido and other things that all go along with this, because muscle mass has direct impact on how much testosterone you have, and you build up fat tissue, and your adipose tissue increases your estrogen level, which can further reduce your sex drive. So there's a whole complex interplay here.
That makes sense.
But again, it all goes hand in hand. And then you guys in their 70s or so just can't maintain muscle mass at that point. And now they're just fighting to hold on to whatever they have. But with that, of course, comes different changes in terms of, you do see testosterone step down, obviously. Now, the why of that is multifactorial, right? Including loss of muscle mass, including changes in normal hormone balance, etc. But yeah, it varies quite a bit. I see that whole spectrum from the guy who's like 30, who's like, what can we do to just make the gym a little easier? And I want to just recover a little faster from my jiu-jitsu. To the guy who was like 7, like, I play pickleball once a week now because my knee hurts for 5 days afterwards. And what can we do about that? Because I want to be doing more exercise. My doctor told me to do more exercise, but I can't do the damn exercise because it hurts afterwards. So now what?
That's when you come in with your regenerative
and
medicine.
kind of that spectrum between there of, 51 years old, and I'm like, I'm tired, I'm sore. This is the first time I really feel like my libido's kind of trash. And do I have low T or not? My sleep's changing for the first time ever, even though I'm not working as much as I used to because I already achieved X, Y, and Z. And this doesn't make any sense to me.
That when I hear that, I'm like, he feels powerless.
Yeah.
He
Well,
feels.
again, it comes back to I'm doing all the right things
Yeah.
and we're not getting anywhere.
Yeah.
Yep.
And so that takes me back to that then impacts his psyche,
Of course.
right? And then that has a ripple effect in so many ways.
Self-perception.
Right.
Yeah,
right.
Take a guy who's in his 40s or 50s, trying to stay in shape, go to the gym, can't put on a pound of muscle mass anymore to save his life, has a bit of a beer belly or just gut in general, even though he's not drinking and doing all other things. And he's like, all right, I'm not feeling that good about myself these days.
That impacts a so lot about
Real
like
fast,
what
exactly.
they do and whether they're married or dating or divorce and all the things. So yeah.
What can I do about it?
And I think for me that what's so important about that is why I'm doing this podcast. It's like the meaning that we make of these narratives that we tell ourselves, right, is part of that. If they don't know that it in some ways is out of their sort of biological control in that moment, that they can then do something about it. If they don't know that, they then make it a me problem.
Yeah, I have to jump in because I think that we probably see the same type of people in terms of these high-performing individuals. And being one of them, I can say also firsthand, I know how to control every situation by applying brute force logic and mechanisms and schedules to it, and I will control anything.
Yes.
And that same mentality can and does fail both men and women who can't brute force through what's happening biologically. Your circadian rhythm degrades with time. You will not sleep as well when you're 70 as you did when you were 40.
Wow.
You can't just will yourself to sleep better.
Yeah.
There's things you can do about it, but you can't put yourself in the, even the best schedule out there, you still won't, right? So, and this is where you really get frustrated because this individual, this personality type, of which I include myself, if I can't control it, it's a me problem.
Yeah.
I just haven't tried hard enough to fix the problem.
Yeah.
And that can get to be a very dangerous, slippery slope because you begin to say, well, until I fix the problem, I will not be, that excited about sex. I will not be this. I will not be that. I will not be doing whatever until I control this. A loss of control is very, very dangerous. I'm right there with them. I understand it.
Yeah, for sure. You just summarized so many of the people that I see in my practice, and it's trying to educate them and relate to them that it doesn't have to be this way, that there is help for you, and that the way you're approaching it isn't going to make it better. It's actually going to make it worse because it's critical. It's like criticism,
higher stress levels, right? Which actually keep you at a higher sympathetic tone, the fight or flight, for those who don't remember, right? So sympathetic tone is fight. Keep a higher tone, which keeps a higher cortisol level, which decreases your sex drive, which decreases your sleep quality, which also decreases your ability to put on muscle mass, and all of a sudden you're spiraling downhill pretty quick. For all the things, that got you here won't get you there kind of thing.
Yeah,
There's a lot of tools that can backfire.
Right.
And again, I think it comes down to, to your point of phrasing, like, but there's a lot of other tools out there that you probably aren't aware of that can help you achieve those goals and still leave you in control. And, tightly in control.
That's right. That's right. So well said. Hey, I literally just got chills, not because I'm cold, but because I've even learned stuff today. And I just want more people to feel like, hey, I have the power to do something about this. I might not be able to do it myself, but I can get the resources. I don't have to live this way. There is something that can be done for me.
There's a lot more tools in the toolbox than I think most people are aware of, whether it's peptides, whether it's stem cells, whether it's like there's a lot of things at play beyond what the average primary care doctor has available because they don't have to play the insurance game.
Tell me more about that, that there's actually so much more that's possible But how does somebody even know to find that?
It's true, like they don't. You hear about it from influencers on Instagram and whatnot, and you're like,
Yeah.
oh, well, maybe there's this or that, but they don't necessarily know where to go looking, unfortunately.
And do the primary care physicians know where to direct them? Like, are they even up to speed about where,
Not
hey, you should?
necessarily. I mean, again, I hate to say it, but like for those who are deeply in that insurance system, it's just a survival game in terms of getting through their own daily work, and that's reality. It's this is the job, and they got to do it, and I get it. They might know about something like me, they might not, but they're certainly not going to have the time or bandwidth to go researching it. If they did, they'd have more time in the day. They'd be using it for their patients. I'm almost certain. The unfortunate gap, obviously, is people don't know that there's a lot of other tools out there. And there's two reasons that this doesn't go mainstream in a way. The first is that insurance doesn't cover it, so your average doctor is not going to take the time to learn about it because they can't get paid and or bill for it, and therefore it doesn't make any sense to do.
Well,
The second, as I mentioned, is the nuance of having to do personalized conversations, which are time consuming and again, antithetical to the way modern medicine works inside the healthcare system anyways. And probably the third, it's a bit of the personalization part is, when you start getting into cutting edge areas, you're dealing with data gaps. And medicine, by training, doesn't like that. And that makes sense. Obviously, you don't want data gaps. You're dealing with human beings and lives, and you want to have as much information as possible. So if you have data gaps, you have to be really deliberate in explaining that to your patient, to your client, saying, hey, we're off script. Like, we're doing things that are not proven, and I can't guarantee this, and I can't guarantee that, and and I'm not even using an off-label. It's not even approved. So we're way off script, and that's a very intense conversation, I guess, or at least time-consuming conversation to say, here's the risks, here's the benefits, here's the great unknown part. If you're 80 years old, you have one risk-benefit calculation. If you're 35, you have a different one. So all that kind of comes together to be problematic, I guess, for bringing this to the forefront.
it's interesting because when I talked to some friends about Peter Attia's book, who I think the book was great, right? But I joke, I love that he put mental health in it, but of course, he had to put it as the last chapter, because if he would have started with that, no man would have read that book.
Definitely a fair point. I would say I wonder if it's true for women as well.
Interesting.
I would ask you, like,
I don't think that.
you don't think so?
No,
High-performing, high-functioning women, power roles?
no. If you made it relational,
Yep,
and not just named it mental health, named it like relational health,
yep.
women would have entered it that way. Even high performing women, because relational health is still very important to us. And I'm not suggesting that it's not important to men. In fact, I think it's quite important to men. It's just, it's almost like that misnomer that men don't care about it. In fact, my experience is men really care about their partner's satisfaction and their contribution to their partner's satisfaction. So I think those are misnomers that gender dynamics sort of miss.
I will say, though, like, mental health as the last chapter in that book wasn't entirely inappropriate if you come out from the premise of mental health is the output and not the cause. Is it the high inflammation? Is it the high stress levels and everything else? Yes, your lifestyle can impact that, but is that lifestyle driving your depression versus the other way around?
So it's a chicken and egg question.
Of course.
Yeah.
Because we know it's both.
Yeah,
we
of course.
absolutely know it's both.
That's right. Yeah, I agree. And it's just always something I've always thought. So we move from emergency medicine to eventually regenerative medicine. What's your why? What's the meaning you're making from that?
Yeah, I mean, honestly, it's one, being able to positively influence people. In emergency medicine, it's an emergency and you're dealing with that crisis. It's not even remotely comparable from a patient population perspective. I guess I'm glad I did that from a career part, but what's changed and what I really love about what I do now is I'm largely working with a very motivated group of people as far as a patient population that is engaged in their health, engaged in their own research. They come and they have questions I don't always have the answer to. Like, they want to see themselves get better, which means that I can bring all my best tools forward and know they're going to use them, and that all that energy and knowledge that I put in on the back end, on the days that I'm doing the research and going to the conference and whatnot, that it has real world outcome meaning, because they're happy to capitalize on it. And I see them actually go from, doing this, is like, well, I'm sleeping better, I'm this better, I'm that better, and life is better thanks to you. And that's not an ER thing. It's a very nice change, we'll go with.
Yeah, that makes sense. In my world, I often say to clients, I'm in it for the transformation.
Exactly. I can play pickleball again. I
Right.
can go skiing this season. I can go skiing this season after we did the X treatment. I'm like, all right,
Yeah,
fantastic. That's what I want to hear.
that's right.
I know what it's like to lose ski season, and I know what it's like to not be able to do that. I'm like, all right, because I've had my injuries, I have my this, I have my that. Even if I'm not a given age, I've certainly had those experiences for other reasons where you're like, so I know what it is to lose some of those things in your life.
To that end, I mean, you took a different path just briefly, right? Like you said, just you went into venture capital, and similar to me, I had a whole career prior to becoming a clinician, and those things are super helpful in how I work with the client population that I have,
people.
for sure. And yet, it wasn't going to be enough for me to stay in that world because I wanted to transform. And I'm not saying that you can't do that in that world, but in the way that was meaningful to me.
Right.
I needed to come into this world and being helpful and healing.
Yeah, I would say mine was more incidental as far as going back into a medical career, for sure. It was much more of this is good work. I enjoy this again. So let's go make it happen kind of thing.
Very cool. Thank you so much for coming.
I really appreciate it.
Yeah, it's been a fun conversation.
Absolutely.
Thank you so much for taking the time to watch and listen. It helps me a lot if you subscribe to our channel here, and look out for future episodes on YouTube, Spotify, Apple, or wherever you get your podcasts.